The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone and welcome to today's CCAN webinar. My name is Lisa Fletcher. I'm one of the 3 CCAN Centre Managers. For those of you who are not aware of CCAN, CCAN stands for the Centre for the Evaluation of Complexity Across the Nexus. We are a research centre that are funded by a group of UK research councils, government government departments and agencies. Our aim is to test and promote innovative evaluation methods that can take into account and are appropriate for the complexity of the world around us. We are in particular looking at nexus issues, the interlinked areas of food, energy, water and the environment. For more information about our events and research, please visit our website and look at the resources and events page. Today's webinar, Developing Microsimulation Models to Generate Evidence to Support Policy Change in Public Health, is presented by Abigail Jacquard. Abigail is Deputy Director of Public Health Modeling at the UK Health Forum. Abigail will speak for around 45 minutes and then we'll have some time for questions at the end. Please submit your questions via the question box, which should have popped up when you joined the GoToWebinar, and we will take those questions at the end. The session will be recorded and will be made available via the CCAN website. I'm now going to swap over the controls to Abigail. Everyone should be able to see Abigail's screen now.
Hi everyone, that's great. Thank you very much for the introduction and the opportunity to speak today. Just to check, can you hear me okay? Okay, so
yeah, they won't be able to tell us. They'll send us some questions. Yeah.
Okay, thank you very much. As I've already been introduced, my talk today is about the work that we do at the UK Health Forum, and in particular the modelling team, and generating evidence to support policy change. So just to go through an agenda for today's talk, webinar, firstly I'll introduce the UK Health Forum, and then next talk about the modelling capabilities that we have and we've developed over the last decade, and also go through some then case studies, so for some example projects that we've undertaken, and also talking about just summarising next steps and what's currently coming soon. So the UK Health Forum, we're a health charity and we're generating evidence to support policy change. We do this by firstly modelling trends in risk factors and disease. And in particular with diseases, we focus primarily on non-communicable diseases, such as coronary heart disease, type 2 diabetes. We also research different interventions and research their impact in terms of improving health outcomes and reducing health inequalities. And we've also then done some work around modelling the potential impact of these interventions on health and economic outcomes in different populations. So they may be a whole population, so at a national level, or maybe local level areas, or particular subgroups or cohorts of a population. We've also extended this modelling capability to others by developing modelling tools for others to use, and this may be directed more at policymakers or analysts within, for example, local government. And alongside this work, we also produce reports and coordinate in advocacy. And our email address is available at the logo below. So why is prevention important? So obesity has been predicted to cost the NHS at least 5.1 billion each year. And these do not include the societal costs. So for example, lost productivity, which are estimated at tens of billions each year. Overweight and obesity is also a risk factor for different types of cancer, for example, bowel cancer, womb cancer, breast cancer, esophagus, and kidney cancer, but also for other diseases such as coronary heart disease, type 2 diabetes, and stroke. Our modelling started with the Foresight project, so the Foresight Tackling Obesities Inquiry in 2007. And the model was generated to assess the impact of different obesity interventions and also to predict the impact of how obesity trends will change in the future in England. Since then, we've further developed the model and also modelled various interventions and risk factors throughout the world, working with key figures such as WHO, the World Bank, OECD and Public Health England. So the types of modelling that we do at the UK Health Forum. So we've developed a microsimulation model, so a computer simulation model, to forecast the health and economic impact of a range of behavioural, so for example, body mass index, smoking, salt consumption, and environmental risk factors, such as nitrogen dioxide and PM 2.5. We've also developed a regression model, which is used to project the following risk factors into the future. So for example, BMI, so in particular obesity levels, smoking prevalence, physical inactivity, alcohol consumption, salt consumption, NO2 and PM 2.5. To complement this, as I've mentioned previously, we've also developed a range of policy tools for policymakers and analysts. And this is a scaled down version of the microsimulation model that we use in-house to undertake the complete analysis of health and economic impacts of different interventions. So our modelling capabilities, we have a very multidisciplinary team, and we range in terms of our modelling works across key areas such as epidemiology and economics. So we have epidemiology and economic expertise in-house. We also look at understanding how trends in the data have changed, and also we run cost effectiveness analysis, and this is more long-term cost effective analysis in-house. We also have a modelling and data science capability, so a strong track record of statistical modelling and data science expertise, and also more recently working on big data sets. And then what forms our interdisciplinary team is the fact that we take the evidence and the results from the modelling studies and actually translate these into evidence that policymakers can use in the form of high impact publications, academic credentials, and we also have a large health network where we use this to disseminate some of the findings. So our current and past stakeholders, so we've worked with a range of stakeholders, both nationally and internationally. So for example, with government, we've worked with PHE, DEFRA, Go Science. We've worked across with different academics across universities, such as Imperial, Oxford, Cambridge. We've also done a number of projects with Cancer Research UK and feeding into their prevention. So around modelling the health and economic impacts on a range of policies which aim to tackle obesity and smoking prevalence. We've also done some work with the World Health Organization, forecasting the future trends in obesity across Europe. And also with the World Bank. So for example, a particular case study is modelling the impact of tobacco taxation on smoking prevalence and subsequent diseases in Ukraine. And this is just to illustrate the partner basis where we've worked with, and it really highlights the importance of the modelling work that we do, but also the dissemination and the range of different areas that we work within. So just to give you a very brief summary of some of the previous projects, I'll go into more in detail. Some of the previous work to date has focused on modelling the impacts of potential policies and risk factors. And this includes modelling the 20% sugar sweetened beverage tax and looking at the impact on health outcomes, but also on obesity rates. Modelling the long-term cost effectiveness of a weight loss trial. modelling the implications of reducing smoking prevalence by increasing the UK tobacco duty escalator, and looking at this in the context of public health and economic outcomes. So this might be a reduction in disease incidence. We've also looked at more recently modelling the health and economic impacts of air pollution. And in particular, these have focused on the long-term impacts of outdoor air pollutants, NO2 and PM2.5. And we've also modelled a range of prevention, screening and treatment scenarios across Europe. And some of the publications for your information are listed below. So the microsimulation modelling. I suppose the question is, what do we actually look at when we've developed these models? So on the left-hand side of this figure, we have the risk factor projections. So this module of our model allows us to use historical and current data to forecast the prevalence of different risk factors. So these may be behavioural, so for example, body mass index, smoking prevalence, but they also may be environmental. A majority of the data comes from national surveys, and we use individual level data to project forwards. We generate these projections by 5-year age and sex groups, depending on the level of data available. And we can forecast these data points 10 to 20 years into the future. However, uncertainty obviously increases with the time frame of interest. These then are fed in as input data into our microsimulation model. And in our microsimulation model, we have a population module where we sample individuals that are used in the microsimulation model. So the idea of the microsimulation model is the fact that we use Monte Carlo trials. So we take sample individuals and we simulate these individuals individually through time. And if we simulate enough of these individuals, we then use this to obtain population estimates of the impact of different scenarios. So our population data is generally sourced, for example, in the UK, we would generally use ONS data. And using distributions, we sample individuals' age and sex from these distributions so that we're gaining a representative sample of our population. We also incorporate mortality estimates to include the chance that an individual may die of a disease that we're not modelling in the simulation. And then we also include births in our simulation, especially in simulations where we're replenishing the population and we're looking at the population cross-sectionally over time. This then moves on to the second module, which is the disease data. So generally, in terms of the disease data, we'll investigate various sources and extract data from various sources in the literature, and also what is available with different data sets that's held online. So this will be data around the incidence rate of particular diseases, the survival rates, so how the probability of an individual dying from a given disease, depending on the number of years that they've had disease. There's also the prevalence statistics that we would read in. And then also we would use the relative risk estimates around these disease data. So this is the link between the risk factor and the incidence of the disease. So the increased risk an individual who smokes have of developing lung cancer, for instance. We would incorporate this data, and this is then complemented with the health economic data. And the health economic data can be both healthcare specific. So for instance, in previous projects, we've used primary care estimates for data for costing, or also secondary care, hospitalizations, and any other healthcare associated costs. What we also include in this module is any wider costs to society. So for example, premature mortality costs, so income costs, absenteeism costs. and a range of other costs. What we can also incorporate in this module is implementation costs of the intervention. So this is used then if we're looking at the cost effectiveness of a scenario. And then finally, the most powerful part to the model is the scenarios. So because we've developed the module in a very modular type way in terms of the architecture, the scenario module allows us to implement a scenario acting on anywhere within the patient pathway. So for example, we can implement a population approach where we reduce the BMI of all individuals within the population or smoking prevalence. Or we can target particular individuals. So for example, we can implement a scenario which just affects a sub-part of the population, and we can implement that. What we can also do is implement scenarios where they act on different points in the disease process. So for example, for an individual who has chronic obstructive pulmonary disease, they generally move through different stages of disease. This is clinically defined as gold staging, and there are specific treatments that can help an individual reduce the progression into a worse stage of the disease. So we can actually implement scenarios which actually look at the health impacts on a population with COPD or a general population, where we apply a reduction in their risk of developing adverse effects of the disease. What we then do is we will model 50 million to 100 million individuals in the simulation, and then estimate the impacts in terms of disease outcomes. So this might be the number of new cases that's avoided as a result of the scenario, and also the economic outcomes. So how much could the NHS save if they were to implement scenario A? And now I'll move on to some case studies, just to give an example of the breadth of the work that we've done to date, and also to illustrate the flexibility and range of modelling activities that the model that we've done and the model can do. So my first case study is the health and economic impacts of air pollution. The air pollution project was carried out in collaboration with Imperial College London, and commissioned by Public Health England, the Health Economics team. Air pollution is the leading environmental cause of premature death. In the UK, it has been estimated that impacts of long-term exposure to particulate matter are equivalent to 29,000 deaths each year. Exposure to air pollution has short and long-term effects on the health of the population, and has been linked to several diseases such as coronary heart disease, childhood asthma, and lung cancer. The main aim of this project was to estimate the NHS healthcare. So this is broken up by primary care, prescription, inpatient and outpatient, and social care costs attributable to air pollution, and also to estimate the future impacts of current levels of air pollution. We did this with our microsimulation model and presented the results in terms of the health and economic burdens from long-term exposure to NO2 and PM2.5. The model simulated populations in England, Lambeth and South Lakeland. And these two areas we used because Lambeth had relatively high levels of air pollutants and South Lakeland had relatively low levels. And in combination with this study, an air pollution tool was developed for local authorities, and this was to allow individuals to assess the future health and economic impacts of air pollution within their local areas. So in terms of the input data, so we were looking at the population within England, Lambeth and South Lakeland. So different population data estimates were sourced from ONS, And this was in the form of age and sex distributions for each of the areas of interest. We also undertook a literature review to identify the relative risks of NO2 and PM2.5 for chronic diseases. And the strength of this evidence did vary between the diseases and the air pollution. And I'll summarise this in the next slide. We also worked in collaboration, as I mentioned, with Imperial College, and the annual concentration surfaces of NO2 and PM2.5 were estimated from land use regression models. And this was the land use regression models were developed in-house by Imperial. And then the costs used, so the economic costs of each disease, were estimated for health and social care costs, and these were sourced partly from the literature, but then also estimated from hospital episode statistics. And this was also done in collaboration with Imperial. As I mentioned previously, the evidence varied in terms of its strength and with the association of between PM2.5 and diseases and NO2 and diseases. So what we've provided in the report is an illustration of the diseases where there was stronger evidence for an association. And so for PM2.5, this was coronary heart disease, stroke, lung cancer, and asthma in children. And for NO2, this was asthma in children. And then we've also included in the analysis, but made clear throughout the report, that there was evidence which was less certain or emerging of the associations with PM2.5 and NO2. And this included chronic obstructive pulmonary disease, type 2 diabetes and low birth weight for PM2.5, and asthma in adults, type 2 diabetes, lung cancer, low birth weight and dementia for NO2. And what we found was, from running the simulations, we found that in 2017, the NHS and social care costs attributable to PM2.5 and NO2 were estimated to be 42.88 million, based on the most robust evidence. So this is just using the first row of the table in terms of the disease outcomes. And if the current air pollutions remain constant, the total cumulative costs, so the total sum of the costs over the period from the start of the modelling, which was 2015 to 2035, would cost the NHS and social care 5.37 billion by 2035, so it's the cumulative costs. In England, current levels of PM2.5 and NO2 are predicted to be attributable to 1.3 million and 1.1 million new cases of disease by 2035. So this is the cumulative incidence, based on the more and low robust evidence, so based on all of the diseases. And this is just to illustrate the flexibility also of the model. So we ran simulations to look at the attributable burden from NO2 and PM2.5. But what we also did was run different hypothetical scenarios. So for instance, for NO2, for example, we looked at implementing a 1 microgram per meter cube reduction in NO2. And also a scenario where we were to reach EU limit values, which is currently set at 40 micrograms per meter cubed by 2035. And as you can see, the total number of cases that could be avoided with these two scenarios. So in red, we've got the scenario 1, which is the 1 microgram reduction in NO2. And as you can see, this has smaller gains relative to the EU limit scenario. So for example, if we were to undertake a reduction of 1 microgram per meter cubed in NO2, we're likely to see, predicted to see, around 7,000 cases, just under 7,000 cases, new cases of asthma avoided with this scenario. And as you can see, there's a much higher reduction in the cases of new cases of asthma if we were to reach EU limits by 2035. This is nearly 70,000. In this graph, the more and less robust evidence has been highlighted, where the bars are a solid colour and a transparent colour is used for the less robust evidence, just to highlight this difference. Quite large reductions are also observed for diabetes, and also then the reductions are much lower for lung cancer, low birth weight and dementia. And these will be partly driven by the relative risks associated with these pollutants, but also the frequency of these diseases within the population. In contrast, this is to show the impact of a hypothetical scenario which reduces the concentration levels of PM2.5 by 1 microgram per meter cubed. And by 2035, it's predicted that around 50,000 cases of CHD could be avoided in the population. And around, for example, in the less robust evidence, around 40,000 cases of COPD. So you can see this has a significant impact on health just from a very small reduction in PM2.5. In combination with this analysis that we did with the microsimulation model, we also developed a policy tool for local authorities. And this allows local users to download this tool, so it's freely available, and I can provide the link separately. And it downloads onto a PC and can be used to simulate either England or a range of other local authorities across England. What you can also do is view and change any input data in the tool, and then also simulate different scenarios for either NO2 or PM2.5. And the tool is a scaled down version of the microsimulation model, and it allows the individual to run cohorts of a population, and you can select particular age ranges, and also males and females, or independently, separately, either males or females. The tool then provides estimates in terms of health outcomes and also in terms of economic outcomes. Moving on to some other work that I'd like to highlight during this webinar today. We've also undertaken previously a case study for modelling the long-term impact of a sugary sweetened beverage tax. This was a 20% tax, and this work was carried out with Cancer Research UK. And this technical report is available online. But what I'd like to do today is just go through some of the other modelling work that we've done and the assumptions that we've had to make around some of those modelling the scenarios. So for a sugary sweetened beverage tax, we modelled this as having an impact on BMI. But what we did was, outside of the model, we obtained estimates for how a sugary sweetened beverage tax may have an impact on individuals' BMI. So we looked at, just in summary, we looked at the price of a sugary sweetened beverage tax. So how might the price of sugary sweetened beverages change with the tax? And then we looked at the current consumption of these types of drinks. And these types of beverages. And then we looked at using different elasticities, how people's purchasing may change as a result of a price change, and how this may then lead to a consumption change and then a body mass index change. And we modelled the effect that this would have in terms of the disease and health outcomes. So we modelled the sugary sweetened beverage tax just in 1 year, but then simulated the model further in time just to look at the long-term impacts of a small reduction in BMI. So from the prior analysis, it was calculated that there was a 0.05 reduction in BMI, and this led to a 5% shift. So, for example, in this table, we can see the baseline, which is assuming that there is no scenario and there's no change, and the trends carry on as sort of status quo. And then we've got the results from a SSB tax, and in 2015 and 2025, we've illustrated from the microsimulation model, the male, female, and both together proportions of percentage of individuals within the healthy weight group, the overweight group, and the obese group. And as you can see with the very right-hand column, in terms of the obesity of males and females, there was a 5% shift, so from around 34% to 29% in the proportion of individuals who were in the obese category with SSB tax. And this is equivalent in the UK to 3.7 million obese people by 2025. And from this, we were able to estimate and predict the result in terms of the avoidance of key diseases that are related to obesity and BMI, high BMI. And this was predicted to have, the SSB tax was predicted to avoid around 25,500 cases of new BMI-related diseases by 2025. So, for example, in CHD, it was estimated there would be a reduction in around 5,000 new cases of CHD. So 5,000 new cases avoided of CHD. And in the 8 cancers, this was predicted to be around 671 new cases in that 10-year period, equating to around 1 million per year in healthcare cost savings. This analysis was previously for BMI, I've discussed, and also air pollution. But also, what I'd also like to talk about today is some of the tobacco modelling work that we've done. So in the model, individuals can be smokers, ex-smokers, and never smokers. And we also they're modelled discretely. But what we also can model is we keep a note of if a smoker moves into and becomes an ex-smoker, how long they've been an ex-smoker for, so the number of years they've given up smoking. And another project actually we also did with Cancer Research UK was modelling what implications may occur from a rise in tobacco taxation in the UK. And then also the case for achieving a tobacco-free ambition. So that's reaching 5% prevalence in smoking prevalence in the UK. These are both available and published online and in Tobacco and Control. If anyone requires any further references after this discussion, that's not a problem at all. I can send them around. Also, I'd like to illustrate some of the work that we've done modelling across Europe. So the way that we've developed the microsimulation model enables us, even though it requires quite a lot of input data, because of the level of granularity with the level of individuals that we're modelling, what we can do with the model is we can actually implement different countries, implement the model in different countries. So we can use different population statistics, different disease statistics that replicate and try and model the current statistics that are seen within those countries. And as part of the CONDA project, so the Economics of Chronic Diseases project, we actually modelled different obesity and smoking related interventions across different countries. And it was a very interesting project in terms of highlighting the need for data consistencies, especially when whether discussions are around making comparisons between different countries, which wasn't recommended in some cases because of the differences in data available. And part of this project, the key objectives were to aid EU member states to develop, select, implement more cost-effective policies to improve chronic disease prevention, but also, as I've mentioned earlier, achieve a consensus on the methodology for measuring cost-effectiveness of chronic disease interventions. And also, as part of this project, we further developed the chronic disease module of the microsimulation model. The idea being that diseases could be estimated through different stages, and by separating those stages out, you can then use different interventions to implement on different disease staging. So, for example, a good example is some of the work that we did around prediabetes, so targeting individuals with prediabetes in terms of a weight loss or BMI reduction, and then modelling the impact then on diabetes incidence. We also, as part of this project, developed a tool that could be used by local users by country users of the European countries that we modelled in the project, to evaluate the cost effectiveness of different interventions which impact on BMI and smoking prevalence in their country. This slide is just to highlight some of the complexities with some of the modelling work that we do, and the complexities of to allow the complexity of the system that we're modelling, but also the way that the model's been developed so that we can actually implement different interventions at different points in the patient pathway. So, for example, we've got in the green box prevention or screening interventions. So in our model, this can have an impact on the risk factor. And we developed this staging for disease severity, and this allowed us to apply different management interventions on different stages for individuals who were within a particular stage of the intervention. And then also, that was complemented with specific treatments or treatments in increasing survival rate, for instance. The key outputs from this project were prevalence and incidence rates, but we also complemented this with quality adjusted life years and disability adjusted life years, and also the total healthcare costs and indirect costs, and also incremental cost effectiveness ratios. In general, just due to the data that was available, we had to use proxy data from the Netherlands and also from the UK for supplementing parts of the model for implementation in different countries. But in general, we were able to source the costs of the interventions and also specific country-specific discounting rates and costs of diseases by stage where possible. So at the UK Health Forum, we use a multidisciplinary approach to modelling the impact of behavioural and environmental risk factors on the incidence of chronic diseases and demand on healthcare. And this is really important because our modelling approach is generated at the very beginning, where we look at the epidemiology and the evidence around the economics of particular diseases. We then develop the model, and then we focus quite heavily on dissemination and presenting these findings in a format that's useful for all users. We also forecast the future impact of different policy scenarios on health and economic outcomes in the form of healthcare and non-healthcare savings. And we also look at the impact of different policy scenarios which may have an impact on risk factors, disease incidence and survival rates on the population, a subpopulation or an individual. And we've also used this work, and there are some publications to date, to predict the long-term cost effectiveness of a randomised controlled trial. So we're able to look at the cost effectiveness beyond the end of a trial by using assumptions agreed with academics in universities. And that was just to say thank you very much for listening today, and if you have any questions, I'll be able to answer those. Thank you.
Yeah, thank you, Abigail. There doesn't seem to be any questions tabled. We'll just give people a moment to type any in to us.
No.
But one immediate question I had was whether or not you've done any post-evaluation work and gone back to look at whether your predictions were true in any of your case studies.
Yeah, so we haven't done that with the microsimulation modeling to date, but actually that's something that is an important point and something that we would definitely be interested in doing. It's just we have to leave a certain amount of time between the end and the beginning of the study for there to be enough data to compare with. But also what's quite difficult is when we're forecasting our baseline trends and our scenarios, these are assuming that everything stays the same based on the current and historical data. So it's the model doesn't take account of any new implementation or any new policy that's implemented, say, a year or 2 years after the model's been simulated. So it's often quite difficult to go back and actually check a specific scenario where there's been some developments in the field or where a new policy's been introduced.
Great, thank you. I see we have a question. Can you see it, Abigail?
Yes, yep.
Do you want to read it out? I don't know if everybody can see these.
So, sorry. So the first question is from Jonathan Ainley. He asks, can you tell us more about the construction and specification of the land use model and how it compares to something like Nevo from Exeter? So the land use regression model for the air pollution project was developed by Imperial. I can send some literature around this. We used the outputs from the modelling, but we didn't develop those models specifically in-house. I know that the air pollution exposure levels were from monitoring stations, and generally at a very low level in terms of their granularity. In terms of the surfaces, but I would need to, I'll follow up with that with an email, and I can put you in touch with either the relevant literature or the relevant publication for that, or the academic who we worked with on that project. And also the next question then is from Sheetal Mistry. Thank you firstly for the presentation, very insightful. How long does it usually take to get the data, prepare it and use the model? Are there any difficulties in this process? And I think this is a really good question. So it's generally quite a long process. So depending on the scope of the project. So we generally would start with a literature review. So, for example, in a project, for example, say the air pollution project, that was the first time we'd actually simulated NO2 and PM2.5. So we had to undertake a literature review to look at the latest evidence around relative risks, which did take quite a bit of time because there was quite a lot of literature around. And the next step then was around gaining insights into the disease statistics. Generally, these are updated more frequently, and we generally keep these data up to date in-house. And preparation, we've developed the model in-house, so we have various tools that we've developed in-house that allow us to read in the data and also clean the data and check for any errors within data processing. Simulating the model, this generally takes overnight for around 50 to 100 million individuals. And it will then depend on the number of scenarios that we're simulating. Sometimes we can simulate 5 different scenarios, and also the time frame of interest. The difficulties with this process are often gaps in the evidence in terms of data, missing data. So we have to sometimes make assumptions. So, for example, for some diseases, we have relative risks for each BMI unit. But for some diseases, we may just have a relative risk for individuals with a BMI of greater than 30, so who are obese. And it's about sometimes working with any collaborators that we're working with in the project, but also working with academics to gain an understanding of the assumptions that we can make around the process without losing any sort of not accuracy, but reliability in the modelling that we're doing. It's great, and I'll move on to the next question. It's from Jose Iparagui. In general, do you simulate parametric changes in the relationships between regressors and outcomes, or do you keep the results from your regression models and literature unchanged across the different scenarios? So this is where it varies. So for the regression model that we have for simulating the risk factor trends, we keep that regression model constant for our baseline trends, and the only thing that often differs is the level of historical data that we have or current data. And then in terms of the different regression models, sometimes, so we use that for the risk factor trends, but then what we'll do is for a particular scenario, we will implement a change either on that trend or generate a new trend using different data. And just moving on to the next question. You have the downloadable air pollution tool. Is there something equivalent for cancer or other diseases? Yes, we have. So we have the air pollution tool, but we also have the tool that was produced as part of the Aconda project. So that tool allows individuals to simulate the impact of obesity-related diseases for different BMI scenarios. So that included the sugar sweetened beverage tax and the multi-component lifestyle intervention. And that had several cancers within those simulations. And also we have a tool for smoking prevalence and looking at the impact of different smoking scenarios and that will include lung cancer and also COPD and stroke, at least, in that tool, and they're both freely available on the website as well.
Great. It doesn't appear to be any more questions, so perhaps I should just say thank you to everyone that's taken time to listen during their lunch hour, and thank you to Abigail for taking time to give us this presentation. As I said, we will upload the webinar on the website with Abigail's PowerPoint presentation and any relevant links, and you'll get an email confirming when it is available. Thank you all, and enjoy the rest of your day.
Great. Thank you very much.
Okay, bye. Thank you. Bye.